dear professors and colleagues. Now I would like to share with you two of our interesting coronary cases, and we'll discuss together their imaging features and the key points that we can learn from each case. First, we'll see the case, and then we'll discuss the findings together. So what we are having here in such case, we have an abnormal vessel that is seen arising from the RCA and passes in front of the RVUT, and another shorter vessel which passes in the proximal interventricular sulcus. The other long vessel reaches the distal interventricular sulcus. There is also another vessel. It's small in size and passes behind the aorta. It is also seen arising from the RCA. We'll highlight the findings together. The vessel which is seen arising from the RCA and passes in the distal interventricular sulcus, we call it LAD, as it courses the same course of the LAD. But we call it long LAD as it has a long course, and because there is another shorter one which is arising from the left main coronary artery and passes to reach the proximal interventricular sulcus. The other vessel is the OM branch, which is seen arising from the left main to supply the left ventricular, left side of the left ventricular wall. It's a small vessel. There is a small vessel also seen arising from the RCA and has an anomalous origin and an anomalous course, retroaortic course, to reach its site at the left atrioventricular groove. So we call it the LCX, but has a retroaortic course, retroaortic LCX. These are 3D reconstructed images for the same findings. This is the left main coronary artery, which gives a short LAD and the OM branch, and this is the RCA, which gives a long LAD, which passes across the RVUT to reach the distal interventricular sulcus. And this is the retroaortic LCX, which passes behind the aorta to reach its normal place at the left atrioventricular groove. And this is the RCA proper. So what is our diagnosis? It's a dual LAD case. Which type? It's type 4. And we'll discuss together the types of, or the subtypes of dual LAD in the next slide. First, we should know that the first three types are common in that both the left main and the LAD proper are present. And in all, the short LAD is seen originating from the LAD proper and pass at the proximal interventricular sulcus, while the first three types will differ from each other by the course of the long LAD. Type 1, which is commonest, the long LAD passes on the LV side of the proximal interventricular sulcus and re-enters again the distal interventricular sulcus. It's usually benign, but it's important not to confuse it with the long LAD with a diagonal branch, as it resembles a diagonal branch. Type 2, the same as we said, that the left main and the LAD proper is present and gives also the short LAD, which passes the same in the proximal interventricular sulcus, while the long LAD here, instead of passing on the LV side, it passes on the RV side of the interventricular sulcus to re-enter again at the distal interventricular sulcus. It's still benign, but you should be aware of to prevent the misinterpretation during imaging. Type 3, the same. We have a left main, we have LAD proper that gives a short LAD, but here the long LAD takes an intramyocardial course, and it either remains intramyocardial till its end, or it emerges epicardially to again re-enter in the distal interventricular sulcus. Our significance here is that the intramyocardial course may be mistaken as bridging, so we should be aware of that type. Type 4 is the same as our case. There is a left main, but here the LAD proper is absent. The left main gives directly the short LAD, And the RCA gives the long lat which passes a pre-pulmonic course in front of the RVOT to re-enter the distal anterior interventricular sulcus. It's the most important variant as it can be mistaken for collaterals that may arise from the RCE to the lat in the case of ischemia, so the surgeons must be aware of before any surgical procedure or catheterization. Our second case. Can you play the case, please? Okay. So what we have in that case? We have a membrane that is seen separating the left atrial chamber into two chambers, a proximal one and a distal one. The proximal one is seen receiving the pulmonary veins, and the distal one is seen connected to the mitral valve, and there is an ASD also, secundum ASD type 2. This is the proximal chamber receiving the pulmonary veins, and the distal chamber connected to the mitral valve and the atrial appendage. We have also dilated RV and RA, and we have dilated also pulmonary trunk. So what is our diagnosis? It's a co-triatriatum, sinister type. We'll discuss it in the next slide. So what is the co-triatriatum? It's a rare congenital anomaly at which the left atrium or really the right atrium will be divided into two chambers by a fibromuscular membrane, and the heart, in this case, we call it a heart with three atria. The commonest type is the co-triatriatum sinister, at which the left atrium is divided, while the dexter, at which the right atrium is seen divided. What its pathophysiology and the clinical impact? The impact of this disease depends on the fenestrations inside the membrane and the blood flow passing through it. And as when the blood flow, when these fenestrations are wide, the blood flow goes easily from the proximal chamber to the distal chamber to the LV, and the patient may remain asymptomatic. But when the fenestrations are very small or restrictive, the blood flow gets obstructed, and it mimics a mitral stenosis physiology and can cause, as in our case, dilated pulmonary trunk, pulmonary hypertension, and pulmonary edema up to right heart strain. So our complications are pulmonary venous obstruction, pulmonary hypertension, up to right-sided heart failure, recurrent pulmonary edema or infections due to venous congestion. Atrial arrhythmia may happen, causing systemic embolism. And when misdiagnosed clinically as mitral stenosis, the patient may receive incorrect treatment if not recognized early, and it may cause sudden death in infants and children if severe obstruction happens and remains untreated. So what is our management? For asymptomatic cases or non-obstructive cases, may require no intervention, just monitoring, but in symptomatic cases, surgical resection is a definitive treatment for this membrane, and it will take excellent outcomes. Or we have tried in selected cases catheter-based balloon dilatation. We have also a recent technique for management of ASD using a closure and plater device. It's a minimally invasive double disc made of nitinol and polyester to close this hole through a transcatheter procedure and allowing for new tissue to grow over that device. We have a nice video to see that procedure.
عجبني قوي. هنا الدكتوره مي
Okay, this is the device after its insertion in the three planes. Thank you.
Thank you very much, Dr. Mariam, Dr. Mona, for very nice illustrative cases. And for sake of time, we'll have to end this session because we have an industry session just starting now by